Welcome to the chapter on the skeletal system. This is Denise Hubble, respiratory therapist, and let's chat about the bones. When we think about the skeletal system, we need to include things like cartilage and ligaments as well, because these things support the skeleton. Also, there are two subdivisions of the skeleton listed here, axial and appendicular. The functions of the bones are amazing. We typically think about the functions of the bones in the skeletal system as in allowing us to be supported and upright, and for bones to have attachments to muscles so that we can have movement. So certainly that's true. Supporting the body is a good example, but protection of the body is very interesting. And I think about the rib cage, and I think of it as a suit of armor, very well designed to protect our soft tissues underneath, like our lungs and our heart and our great vessels. It is an amazing design. And when we think of a patient that presents and emerges with chest trauma and multiple fractures of their ribs, we immediately worry about the integrity of the soft tissues below. Is there bruising, for example, of the lungs or the heart? So that's important. When we have fractured ribs, we worry about injury to the soft tissue below. As well as we have fractured skull, then we need to worry about how are the soft tissues below. So is the brain injured, for example? And then we see that, of course, skeletal muscles attached to the bones to allow movement. And I think we all know that there's storage of minerals in the bones, like calcium and phosphorus. But interesting that we also store fat in the bones. I've had some patients before that have had fractured bones, and it resulted in small fat particles being released and then actually floating in the bloodstream. That's called fat emboli, and that has caused pulmonary embolism in some of the patients I've seen. So it's very interesting. Also interesting that the bones are very active, actually. They are factories for blood cells, so that is called hemopoiesis, blood cell formation. So it's our bones' job actually to produce blood cells. We are going to be studying the structure of two different types of bone tissue, compact and spongy bone. Here we can see an example of how spongy bone and compact bone are aligned. For example, in the skull, we see that compact bone is on the outsides and spongy bone is in the middle. Here are the types of bones, and our humerus, which is our upper arm area, is made up of a long bone, and I think that's sort of the traditional bone that we typically think of. But bones come in other shapes too. For example, a good example of a flat bone is our sternum, or our breastbone, we would think of that. And the vertebrae are in a category called irregular bones because they're kind of hard to classify. They have unusual shapes. And then short bones can be found in your ankle, known as the talus. The long bone has the long shaft on the length of it, and this makes up most of the bone's length, and it's made up of compact bone, which we'll be studying. It has an outer layer called periosteum, which wraps around the diaphyses, and I think of it as being sort of stapled in place with Sharpie's fibers. It secures the periosteum to the bone. This is an excellent image of a long bone. So let's take a look at this. So in the middle, again, we have the diaphyses made up of compact bone and wrapped with periosteum, secured in place with Sharpie's fibers. In the middle of that is a hollow cavity, which is filled with the yellow tissue we see there. That is fat or adipose tissue inside the long bone, because we know that bones actually store fat, and there it is. At the ends of the long bone, we see epiphysis. A proximal epiphysis is closest to the body, and a distal epiphysis is furthest away. And it's kind of the bulging out part of the long bone. Wrapped around that is articular cartilage, which is designed to reduce friction at the joints. We also see here an epiphyseal line. We're going to learn about that is the old growth plate from when you were a child and your bone was still growing in length. Here's a more up close view of a long bone. And so we're looking at the shaft of the long bone. We see that it's made up of compact bone in a really interesting design, and that area is wrapped with the periosteum again, and that periosteum is secured in place with Sharpie's fibers. Also, we see that yellow fat in the middle of the shaft, in that hollow area called the medullary cavity. We have the fat stored, or adipose tissue. The epiphysis is at the ends of long bone, and it's made up of spongy bone with a thin layer of compact bone around that, and then articular cartilage around that, which is made of hyaline cartilage, and it reduces friction. Also, in adults, we can see an epiphyseal line, and it's leftover or a remnant of the epiphyseal plate when we were a child. And what it did is it was made up of hyaline cartilage, and it allowed the bone to grow in length. If you've ever heard of somebody who fractured a long bone, they may have been asked or may have been checked to see if it was on the epiphyseal plate if they were a child, because it would affect the growth of that long bone if that epiphyseal plate was affected. And endosteum is the connective tissue that lines the inside of the long bone shaft, or the medullary cavity. And we know that the medullary cavity contains fat in adults. In children, it actually contains red bone marrow to allow a lot of production of blood cells. Now, fortunately, we don't need to memorize all of these bone markings. We're just going to highlight a few here. So you should recognize that tuberosity, crest, trochanter, and tubercle are all projections of the bone on which muscles or ligaments may attach. We should know that a bone can have a head and a facet. We don't need to memorize the others. And here, let's just memorize the term fissure, which is a slit-like opening, foramen, which is a round or oval opening in the bone, and fossa is like a dip or a little basin or depression in a bone. Also the term meatus, which is a tunnel in the bone. Spongy bone is where blood cells are produced. This is an excellent picture that looks at the anatomy of the compact bone in the long bone. So what we need to appreciate is that we have these living, mature bone cells called osteocytes living inside this structure, kind of like a person living inside of a house. The person is alive and the house structure is dead. Same kind of idea with the compact bone. So we have osteocytes living inside the structure. In this image, they are within the little star-shaped areas called lacunae. So we can see those in the tissue. They look like little stars. So those are called lacunae, and inside there we have the osteocytes. So also what we have are concentric circles. We can see that we have these concentric circles called lamellae, and they are around a Haversian canal. The canal in the middle is where the blood vessels are located. So we can see that they're indicated in red and blue, the blood vessels, and they're inside the Haversian canal, also known as the central canal, and around that we have concentric lamellae. Altogether, this is termed an osteon, or a Haversian system. So this is sort of the structure of the compact bone. So we have all of these osteons, or Haversian systems stacked together lengthwise. And then around the outside of that, we have additional layers of compact bone, And then outside of that, we have periosteum, like we learned before, and that is secured in place using Sharpie's fibers or perforating fibers. Also, we've talked about blood vessels and how they're running along inside the Haversian canal, but they also run through perforating canals or Volkmann's canals. We see these labeled on the diagram as well. Those Volkmann's canals are running perpendicular to the Haversian canals. Basically what we're getting is a network where the blood vessels can run within the bone. It also makes us understand that bone is very vascular. In fact, we're going to learn that we can inject drugs and fluids into bone tissue and expect for it to get picked up quickly by the blood supply and carried around the body, because we're learning here that the bone has a great deal of vessels inside of it. Okay, we don't want to miss out on the inside lining of this bone. We have a bit of spongy bone there, we see, and we would have endosteum in that area as well, layering the inside of that shaft. Great image showing the osteocyte or mature bone cell, which is alive, living inside of a lacunae. That's kind of like the little opening in the bone where the living cell can live. Within the compact bone, there are tiny canals that radiate out from the central canal to the lacunae. These are called caniculi, and they allow movement of nutrient supplies for the bone cells. What an amazing design your bones are. We see here that they're quite lightweight, but they are strong. They contain things like collagen fibers to make them flexible yet still strong, and they contain deposits of calcium and phosphorus, and this helps them to resist compression. Think of your vertebrae and how it needs to hold up your head for your lifetime, and all of the weight of your head pushing down onto your vertebrae. It makes us realize that our bones need to be able to resist compression. In the fetus, a hyaline cartilage model is formed, which looks like the structure of the skeleton. It is gradually replaced, for the most part, with bone tissue. And that's what this slide describes. That osteoblasts, which are bone building cells, cover the hyaline cartilage model with bone matrix. And then the enclosed cartilage is digested away, opening up the medullary cavity. In a fetus, the hyaline cartilage model is gradually being replaced with bone tissue. We see that the bone tissue replaces most of the hyaline cartilage. In a child, we see that the remaining cartilage includes articular cartilage and the epiphyseal growth plate, where further growth of the long bone is occurring. Also, a medullary cavity has formed. The term appositional growth means that bones can grow in width. This is done by osteoclasts laying down more bone around the periosteum, so the outer side of the long bone, and osteoclasts are working on the inside of the bone, on the endosteum area, to remove bone and create a larger medullary cavity. This bone growth is controlled by many things, including some hormones like parathyroid hormone, for example, some growth hormone, and sex hormones. Parathyroid hormone's job is to be released when calcium ion levels are low, and then that parathyroid hormone actually tells osteoclasts to break down more bone, and this causes a release of calcium into the blood. This is an excellent example of negative feedback mechanism. If, on the other hand, there is too much calcium in the blood, the osteoblasts will store more calcium into the bone. Also, the effect of gravity on muscles affects where there's going to be more bone building. For example, if you're a weightlifter and you are stressing your bones in certain areas, then those bones will actually grow to be larger to accommodate that workload. We see many bone fractures in the emergency department as a perfect example. There are lots of names of types of bone fractures, but they do mean a break in the bone. A closed fracture means that the bones do not penetrate outside of the skin, whereas an open fracture means the bones do penetrate outside of the skin. An open fracture is known as a compound fracture as well, and they have increased risk of infection because you've broken through the skin. When these patients present and emerge, often what will happen is they'll be given some sedation and analgesic, and we would call that conscious sedation, for example. And then the physician will manually adjust the bones until they are placed in good placement so that they are actually lined up properly, and then cast the area and keep it casted or support it in some way for 6 to 8 weeks until it heals. If it's more complex than that, the patient may have to go to the operating room and have open reduction done, where random pins and wires and plates are used in order to stabilize the bone. Here are some additional names of types of bone fractures. I find them interesting. I won't be quizzing you on these names. It's exciting. We're getting into the actual naming of bones. Let's walk through these bone names. Starting at the head, we have the skull, which is made up of the cranium and the facial bones. We'll be breaking those down more in detail in a bit. And then we have the clavicle, what we used to call the collarbone. And the scapula is on your posterior, on your back. And then we have ribs and a sternum, which we also know as a breastbone. In our upper arm, we have the humerus. It is quite funny when we hit our funny bone. It's humerus. And then in our forearm, we have the radius and the ulna. The radius is on the thumb side, and the ulna is the opposite. The carpals are in your wrist, and the metacarpals are in the palm of your hand. The phalanges are your fingers, and then we have also a term, the thoracic cage, which includes, of course, the ribs and the sternum, and this forms a very nice protective structure for the lungs and heart, and great vessels. Also, the vertebral column includes all of our vertebrae, and our upper leg includes our femur. We have a kneecap, which we know is the patella, and in our lower leg we have the tibia and the fibula. And the way I remember those is the fibula is a little bit more narrow, so it is fine, FF, fine fibula. And in the ankles we have the tarsals, and in the mid-foot area we have the metatarsals, and then our toes are the phalanges. Also, we skipped the hip bone, but that will come back a little later. The cranial bones form the skull. They have a very important job of protecting the brain. Of course, it's very delicate and important tissue, so we need to have a very strong structure. Sadly, though, the cranium, or the skull, is a closed container. It forms a closed container in adults. What that means is that if the brain swells, it has nowhere to swell into. So the pressures rise very easily in the brain in the case of cerebral swelling or cerebral edema. Also, just want to mention here that there are facial bones we're going to be looking at. And of course, they hold the structures of the face, like the eyes, and there are numerous muscles in the face to allow us to express our feelings. The bones are joined by these lines called sutures, and the mandible is the only freely movable bone, actually. So we're using that when we're talking. It's useful to learn some of these terms of the skull bones, the cranial bones, pardon me, because a lot of the other names are related to these names. So let's start off on our forehead. We have a frontal bone, and behind that we have two parietal bones. Near our ears we have two temporal bones, and at the back of the head we have the occipital bone. Below our nose, or in the area of our nose, we have the maxilla, and below that we have the mandible. The mandible is what moves when we're talking. Also, we have the ethmoid bone and the lacrimal bone. This shows another view of the bones that I just mentioned. You only need to remember the ones that I mentioned in the previous slide. We have 8 paranasal sinuses. These are hollow structures in the nasal, around the nasal cavity, pardon me. It is believed that they function to lighten the skull and to affect the sounds that we make when we speak, so vocal resonance. I'll pronounce these sinuses for you. We have the frontal sinuses, the ethmoid sinuses, the sphenoidal sinuses, and the maxillary sinuses. The hyoid bone is unique because it is the only bone that does not articulate or connect with another bone. It is helpful when swallowing and speaking, and it serves as an attachment point for the tongue. Our body has the amazing vertebral column made up of 26 vertebral bones, all stacked on top of each other, each with an intervertebral disc between them. Also, within the middle of these, there is a hollow opening so that the spinal cord can run the length of this. This is kind of an amazing design. We see that the vertebral bones are very complex. We're going to look at those in a moment. And we label them slightly differently. So there are 26 in total. There are 7 cervical, 12 thoracic. Each of those have 2 ribs coming off of them. 5 lumbar vertebrae in your lower back. There's a sacrum, which is actually the fusion of 5 vertebrae, and a coccyx, which is the fusion of 3 to 5 vertebrae, depending who you are. Here we can see the vertebral column looking from the side, and on the left hand side is anterior, on the right hand side is posterior, or the back of the patient. So the first 7 vertebrae are called cervical vertebrae, and we also call them C1, C2, C3, C4, C5, C6, and C7. C1, the first cervical vertebrae, has another name, Atlas, named after a Greek god who carried the whole world on his shoulders, I guess. So it's a similar idea. We're carrying our whole head on top of C1, so it's termed Atlas as well. C2 has another name as well. It's called Axis. And then we move on to C3, C4, 5, 6, 7. Next, we start with our thoracic vertebrae. I think we agree that each thoracic vertebrae has 2 ribs coming off of it. They are called T1 to T12 as they move downwards on the vertebrae. And then the next section are the lumbar vertebrae, and we call those L1, L2, L3, L4, and L5. The next section is the sacrum. It has 5 fused vertebrae into one bone. And then we have the coccyx, and it is made up of 3 to 5 fused vertebrae. We also notice here that there are normal curvatures to the spine. That is completely normal. And we see that there are intervertebral discs. They're shown in light blue here. They have a very important function, and that is to act as a cushion between the vertebrae. So very important, we have these intervertebral discs. Here I'll highlight the names of the things we need to remember. First of all, at the top of the slide is posterior, so the back of the patient, and at the bottom is anterior, the front of the patient. This is an example of a vertebrae. It has a body. It has a spinous process, which we can feel on some of our vertebrae, actually, when we feel at the base of our neck. Also, it has transverse processes that kind of point outwards, and it has a vertebral foramen where we understand that the spinal cord is passing through. Isn't the thoracic cage an amazing structure? So posteriorly, it's made up of the thoracic vertebrae. We know each of those vertebrae have 2 ribs coming off and wrapping around and downwards towards the anterior of the body. And then those ribs connect via cartilage to the sternum. So this structure forms sort of an enclosement around the lungs and the heart and the great vessels. And the goal here is that we are protecting those organs. Also, let's talk about the sternum for a moment. The sternum has a manubrium at the top, then a sternal angle where it connects with the body, and then it has a xiphi-sternal joint where it connects with the xiphoid process. Also, we should mention here that some ribs are called true ribs. Those would be ribs 1 to 7, and they connect more directly to the sternum. False ribs do not connect directly to the sternum. They connect to one another and then connect to the sternum. And floating ribs do not connect at all. They are ribs 11 and 12. Up until this point, we've been talking about the axial skeleton mainly. Now we're going to talk about the appendicular skeleton. This basically makes up your arms and legs, and your pectoral girdle, which is your shoulder, and your pelvic girdle, which is your hips, basically. The pectoral girdle is made up of the clavicle and the scapula, and they allow the humerus to connect, so the arm to connect to the shoulder, basically. The great point about this, the good, is that there's great flexibility and movement in that joint. The bad is that it is poorly reinforced, and we know that this joint can have a lot of dislocation issues. Here We see the clavicle on the anterior of the chest and the scapula on the posterior of the chest, and then we see the humerus in that joint. When we take a look at the hand, we see that it's very complex, as we know. The carpals make up our wrist bones, and there are 2 rows of 4 bones in each hand. And then the metacarpals make up our palms, 5 per hand, and then the phalanges make up our fingers and our thumbs. So we have 14 phalanges in each hand, and in each finger there are 3 bones, but the thumb only has 2, which we can notice when we bend our fingers and thumb. Here in the fingers, we notice the phalanges, the distal, middle, and proximal phalanges. We see the metacarpals in the palm of the hand, and we see the carpals. We do not need to memorize all those carpal names. The pelvis is made up of 2 coxal bones. Each coxal bone was made by the fusion of 3 previous bones, ilium, pubis, and ischium. They combine together to form 1 coxal bone, and then we put 2 coxal bones together to form the pelvis. Just pointing out the pubic symphysis on the lower portion of the slide. This is a cartilage that in pregnant women, it becomes a little bit more relaxed to anticipate the vaginal delivery of a child. And this can make it quite uncomfortable for walking and make the mom feel a bit uncomfortable and unstable. Also, part of the pelvis includes the sacrum and the coccyx. The femur is the heaviest and strongest bone in the body. The femur is a typical long bone, and we know that inside of a long bone there's a medullary cavity which is full of fat. I have had some patients in the past who have had broken or fractured femurs, and it's created the release of fat which has been picked up by the bloodstream and is called fat embolism. When we have some of this fat material moving in the bloodstream, it can cause problems such as pulmonary embolism. Just interesting. So the femur is in the upper part of the leg. The lower part of the leg has a tibia and a fibula. And we remember that the fibula is fine and it's a little bit more thin. The foot has tarsals, so there are 7 bones, and the calcaneus is a heel bone. The metatarsals are in sort of the mid portion of the foot, and then, as we mentioned, the phalanges make up the toes. Studying purposes, it's important to understand distal, middle, and proximal phalanges, know where the metatarsals are, and the tarsals, and the calcaneus, but do not worry about the naming of all of the tarsals. Joints are what allow us to move. They allow mobility. They are also known as articulations, and they are where 2 or more bones meet. They need to be held together securely so that they don't fall apart easily. Joints can be classified in 2 different systems. One is the functional, as in how well does it move, type of classification, and one is structural, as in what types of tissue make it up, classification. So in the terms of the functional classification, there are 3 names. Synarthrosis is it's an immovable joint, like the sutures in the skull. Amphiarthrosis are slightly movable joints, such as what connects the coxal bones in the pelvis. And diarthrosis are freely movable joints, like in our arms, for example. We can move our humerus readily from its position. In terms of the structural classifications of joints, we can use these terms: fibrous, cartilaginous, and synovial, and they describe the type of tissue that the joint is made up of. Most joints are synovial and are very, very freely movable. Synovial joints make up the majority of joints, and they're very interesting because they contain a capsule full of synovial fluid which reduces friction. There are several types of synovial joints, and they're listed here.